Welcome to our training on collaborative, community-based services for children with problematic sexual behavior, child victims, and families. My name is Deborah Bell, and I am with CenClear Services in the Clearfield office. The director of our Healing After Trauma program, of which I'm the clinical supervisor and which provides this service for problematic sexual behavior in children. We are out of the Clearfield office. Our phone number is 814-765-1149. Our emails will be given to you again later, but they are on this screen. First, we need to give acknowledgement to the faculty of the National Center on the Sexual Behavior of Youth and the staff at the Oklahoma University for developing this modality that we use to treat children with problematic sexual behavior. This is just a friendly reminder to be aware of your own mental health and possible triggers, and take a break if you need to during this presentation. Today, we will be discussing what we define as a child with problematic sexual behavior, child characteristics, and some common misperceptions about these children. We will focus on how these behaviors originate, effects of these behaviors on the child and others, and how we can successfully treat these children with these behaviors. Finally, we will identify how to identify a child who could benefit from treatment, as well as how to initially respond if you become aware of a child with a problematic sexual behavior. We want to begin by using a quote from Toni Cavanaugh Johnson, who has spent 35 years working with these children. She has written 5 books, 2 booklets, developed 3 therapeutic games, published numerous articles in refereed journals, and written book chapters on children with sexual behaviors and child sexual abuse. Children are like sponges. They absorb the behavior, values, attitudes, and feelings of those around them. The youth who have learned these behaviors, attitudes, and feelings can learn new, more beneficial behaviors. It's crucial to remember that these worrisome sexual behaviors are just developing. No deeply rooted patterns have been set, and children change rapidly as they grow up. They are malleable and can absorb healthy attitudes, behaviors, and feelings about sex and sexuality. Providing a sexually healthy and safe environment is essential for future development. With treatment and community-based supervision and monitoring, recidivism can be reduced, victims can heal, and parents and caregivers can be empowered to help continue this shift towards health and wholeness, working on the front lines with their children and families. To understand the totality of the information we will be providing to you, we must clearly define what we mean by a child with problematic sexual behavior. So take a look at these pictures. These are children, any of them, who might exhibit problematic sexual behaviors. They are children first. Terminology is important when working with these children and families. First and foremost, they are children. They have inappropriate behaviors that can be changed. We need to understand the impacts of these behaviors and provide interventions that can best help the changes to occur. These are not little perpetrators. They are children. Working with or interacting with these children may bring up personal thoughts and feelings that are uncomfortable or upsetting. So make sure to be in touch with your own thoughts and feelings and seek support as needed. Using the term children with problematic sexual behaviors is more developmentally sensitive and separates the behavior from the person of the child and from delinquent or criminal acts that are present in some adolescents and adults. The definition of children with problematic sexual behaviors includes children who are biologically or developmentally aged 3 to 12 years old and exhibit clinically concerning behaviors, including those that are sexual. These behaviors might be partially related to a variety of diagnoses. These children have no distinct profiles. They could be any gender orientation, be from different ethnicities, races, may have a variety of diagnoses, might not have any diagnoses. They might be different ages, might be from different types of family systems. There is no distinct profile. To identify that a child is having a problematic sexual behavior, first we need to discuss what the typical child sexual behaviors are. Humans have may have what may be considered sexual behaviors from the time they are born. Sexual behaviors are those that involve parts of the body considered private, such as genitals, breasts, buttocks, and possibly lips. Children will explore, have spontaneous sexual play with other children, and it's developmentally appropriate for this to play to begin when it is with children of similar ages, sizes, developmental levels, and meets culturally or socially relevant rules of behavior. These typically are behaviors that are happening with people, the children, with other children that the child already knows and are comfortable with. And initially, the behaviors may be outward and spontaneous, but as a child gets older developmentally, they might try and conceal these behaviors as they begin to understand privacy factors. These behaviors, when developmentally appropriate, would always be with mutual agreement, and there's no feelings of fear, anxiety, or anger. Sexual behavior is on a continuum. There's normal expected sexual play. The children are curious, they want to explore. Think of that child playing doctor. Inappropriate sexual behaviors are those that the child is doing that's not appropriate according to social or cultural norms or developmentally, but what they're doing while being spontaneous or exploring, they can be easily redirected. For instance, children playing doctor are taught, we don't touch, we don't look at our friends' body parts, and then they cease the behavior. But what leads to the concern that behaviors are now becoming problematic sexual behaviors? The guidelines for determining if a sexual behavior is problematic in children involves understanding of the frequency of the behavior, developmental considerations, and harm. Some behaviors may be deemed appropriate, but are occurring more often than developmentally appropriate. For instance, this might be masturbation might be accepted within a family, within a social system. However, if it is occurring every day, hundreds of times during the day, or cause harm, there might be a concern. So it might be occurring more often than is developmentally appropriate, and it's unresponsive to the typical caregiver strategies to intervene and have the behaviors stop. When these behaviors are occurring between children who are significantly different in age or developmental states, as such as a developmentally disabled child, it also would be considered problematic. Harm is seen as anything intrusive, forceful, coercive, causing emotional distress in the other child, or being illegal. So we have discussed that there are no distinct profiles for these children. They often have co-occurring diagnoses, even especially those with impulse disorder or impulse-driven types of diagnoses, trauma-driven diagnoses. However, internalizing disorders such as anxiety can also lead to these behaviors because there might be a purpose with the behavior of soothing themselves. Developmental disabilities can even impact because the child may not understand socially acceptable rules, and what they're doing just feels comfortable or interesting. So let's talk about some common misperceptions regarding children with sexual behaviors. First, often there's a fear that a child needs to be removed from the home or school or community and put into placements. This is often not the case. We will discuss this further later on in the presentation. When treatments are used that are usually used with adolescents or adults, these are not usually as effective and also have been shown to end up increasing problematic behaviors in the future compared to when the child receives evidence-based treatment specialized for children. Problematic sexual behavior does not usually reoccur when the child has successfully completed treatment. All children with problematic sexual behavior have not experienced sexual abuse, and often arousal is not even the purpose of these behaviors. As noted earlier, it could be as simple as the behavior is being used, for instance, maybe masturbation. It might just feel good and be soothing when somebody has anxiety. While parental behaviors may impact the child relating to these behaviors, often the parents haven't behaved in any way to model inappropriate behaviors. Social media, for instance, impact the child. There are several billboards out there today that have very sexualized pictures on them even. Any of these could influence a child. Children learn from their environment as a whole and not just the parents. Let's discuss further what may lead a child to have these inappropriate behaviors. Research has been done, and this is listed on the screen, related to children with problematic sexual behavior. In the samples used, and it was 4 different research articles that were used for this. In this research, the samples used a sexual abuse history in children with problematic sexual behavior could have been anywhere from 4% of the sample for one research, clear up to 98% of those children had a previous history of sexual abuse. So findings, therefore, on these different research articles are pretty much across the board in relationship to what they have figured out and about children who both have been sexually abused before the problematic sexual behaviors and those who never had any sexual abuse history. Of those who do have substantiated abuse, though, 36% of those were preschool age children and 6% were school age children, meaning the younger children, not adolescents. Sexual abuse history was more likely in females. Some factors potentially influencing problematic sexual behaviors are child vulnerabilities, family adversity, modeling of coercion, and modeling of sexuality. Some of these might even overlap, and this increases the possibility of problematic sexual behavior. More specifically, child behavioral concerns, developmental concerns, impulse control concerns, and communications delay may influence a possibility of problematic sexual behavior, and also in the difficulty of successfully intervening with these. When caregivers have difficulty for various reasons, such as a lot of children in the home or in the classroom, to have increased supervision ability, the parent might have some issues with that. Or maybe the parent has some parenting education needs that might also influence the possible increase in these behaviors. Single parents often struggle with having enough time and ability to do supervision of all their children on a constant basis. Parents who have their own mental health or substance abuse history may also struggle, and they might have a trauma history that impacts their ability to provide the needed guidance to their child or their response to their child who has begun to have these behaviors. For instance, if triggered, they might even overreact to some developmentally appropriate behavior, and the parent might parent more harshly. Lower socioeconomic statuses influence these other adversities as well, as we've been seeing through the ACEs assessments research that has been done for many years. When a child is exposed to physical abuse, domestic, peer, or community violence, or harsh parenting practices, we see an increase in these behaviors. When a child is explicitly exposed to sexuality or modeling of sexual behaviors, or have been the victim of sexual abuse through penetration or by multiple perpetrators, we may also see an increase in these behaviors. These types of influences are impacted by cultural beliefs, family attitudes, and educational practices. Values and beliefs about intimacy and relationships also will impact what is acceptable or seen as acceptable. Some families, for instance, have no concern about a child or parent walking around in undergarments throughout the day. Complex familial, social, developmental, and perhaps biological factors might also play a part. Sexual abuse, as noted in previous slides, can impact with increasing concerns if there were multiple perpetrators or penetration. Solofsky in 2015 identified some supportive factors that can help diminish problematic sexual behaviors in children or reduce the possibility of problematic sexual behaviors. These are healthy boundaries being supported and modeled, protection from harm and trauma, appropriate parental guidance and supervision, adaptive coping skills, the child having successful experiences or skills in the past, healthy age appropriate relationships, and open communication with trusted adults. Now that there's an understanding of what problematic sexual behavior is in children, what might lead these behaviors and what might help protect these children from developing behaviors? Let's discuss the effects. These pictures show that the family or society might be influenced. The children involved may be influenced. School systems will be influenced, and there might even be legal issues. Problematic sexual behavior is a family and societal problem. The children who act out these behaviors often do this within their social network, especially within the family. These behaviors and caregiver reactions will impact not only that child, but the children and others in the home. Just imagine what it would feel like for you to find out that one of your children has displayed inappropriate sexual behaviors, even if it's outside of your home. Maybe a school has called you. Caregivers may feel a lot of negative emotions, both towards a child who has the behavioral concerns, feelings of shame, guilt, embarrassment, or disbelief that the behaviors even might have occurred or could occur. They might be angry at the other child. Loyalties may become divided. For instance, the child who has the behaviors might be seen as a bad child, while a sibling begins to get a lot of attention, extra attention, due to being the other party. The way caregivers react may relate to their own history or belief systems, and some parents don't even realize how serious sexual behavior problems might be. Sometimes we hear, for instance, boys will be boys, or what's the big deal? No one was hurt. Some caregivers may believe the myths that we discussed earlier and have little hope of finding help or improving the behavioral concern. Some fully blame themselves or the child and believe the child needs to change, or they don't blame themselves, they blame the child and believes the child needs to change, and they can do so even without caregiver help. What's the impact on the other child that might be involved? Well, this would depend on how scary and upsetting the behavior was, how often it occurred, if it was really intrusive, what that relationship with between the children was like before, and the support that they received after the problematic sexual behavior occurred. These children might feel confused, anxious, sad, have fear, start to have problems within relationships or other behavioral issues, or they might even begin to display their own problematic sexual behaviors. When a child has a problematic sexual behavior, whether they occur in school or not, there may be some changes within the school experience. Depending on the concern, the school may need to be made aware for safety planning, the minimal amount of information necessary regarding the behaviors. There may be discomfort among peers and teachers, uncertainty about how to address the behavior, fear that the child could cause more harm and should not be in the school setting. Peer relationships may start to decline also, which creates more emotional concerns within that child. As children age, there are concerns about if the behaviors are potentially illegal, and the justice system needs to get involved. As noted before, children with problematic sexual behavior, school age, are ages 7 to 11, and they begin to meet possible legal impacts as they get older. Questions about if the law becomes involved and how this will influence the child's future and what impacts it might have on the child's family, depending on the punishment. I am going to correct what I said recently. I said it's for children ages 7 to 11. The actual age group is 7 to 12. The hope is that with a child with problematic sexual behavior, that they get the correct treatment to alleviate any legal concerns and reduce the negative impacts that are happening as a result. Let's discuss some of the research that helps to describe what is effective treatment for this concern. A meta-analysis was done in 2008 by St. Armand, Bard, and Solovsky regarding effective treatment practices to identify the elements of treatment that could lead to greater reductions of problematic sexual behavior. They looked at 11 studies and 18 types of treatment. The focus was on children for which problematic sexual behavior was the primary or secondary target for treatment. The findings indicated that the greatest prediction for reductions of PSB was the inclusion of parent behavior training. The training and other strategies which they found worked included sexual behavior rules about boundaries, abuse prevention, and sexual education. Also, the children learned self-control strategies. What they found also was that practice elements evolving straight from adolescent and sex offender treatments were not significant in leading to greater reductions of problematic sexual behavior in treatment. So which therapy models have been found to be effective after 10 years? Carpentier, Solovsky, and Chafin did a 10-year trajectory study, including children who received dynamic play therapy, children who received problematic sexual behavior, cognitive behavioral therapy, and children who were in a comparison group who had disruptive behaviors but did not display any problematic sexual behaviors. The study found that the recidivism rate 10 years later was highest for those receiving the play therapy. This was 11%. For those who received problematic sexual behavior cognitive behavioral therapy, the recidivism rate was only 2% 10 years later. And for those children who had no initial problematic sexual behaviors, 10 years later, 3% of those, even more than those that had received the PSB CBT, 3% of those had begun to have some problematic sexual behaviors. These were the children that started out without any and were being treated for disruptive behavior disorders. The comparison group in this case was similar to all the other children, except that they were more likely to be male. So, what do these studies indicate overall? That problematic sexual behavior, cognitive behavioral therapy works. It provides the caregiver and child support that's been shown to be the most effective. The recidivism rates for children with problematic sexual behavior after treatment is very low. There is no current research showing a clear link between problematic sexual behavior in childhood and illegal sexual behaviors in adolescents or adults. What is problematic sexual behavior cognitive behavioral therapy for school-age children? This is meant for children ages 7 to 12. It includes 18 ongoing sessions, which both the parent and child need to be involved with. Some of the weeks are done with both the parent and child together, and some of the weeks do the parent and child separately. But all the weeks include both in some way. While this treatment is for 7 to 12-year-olds, if the child is developmentally age 7 to 12, for instance, more advanced at age 6, or having some developmental delays at age 13, for instance, they might still be appropriate. This is something we can look at. This treatment focuses on behavior parent training, the most important influence found in studies to impact this treatment. Rules about sexual behaviors and boundaries, age-appropriate sexual education within the family's cultural and family beliefs, with the parental agreement in what will be discussed and how much will be discussed, abuse prevention skills, safety planning, emotional awareness and expression, anxiety management and coping skills, impulse control for the child, appropriate social skills, and empathy development are all addressed before someone can graduate from problematic sexual behavior cognitive behavioral therapy. This treatment is a family-oriented, cognitive behavioral, psychoeducational, and supportive treatment designed to reduce or eliminate incidents of problematic sexual behavior. We really focus on parenting and religious values and beliefs in the context of child development and addressing the sexual behaviors within the scope of treatment. We involve family and other support systems in the child's treatment and require the weekly caregiver attendance and active participation. And they need to be monitoring and supporting the child's applications of skills the child learns and that they learn between the sessions. And we do an ongoing assessment of the child's progress in treatment. There may or may not be a history of trauma, although sexual or physical abuse and witnessing of domestic violence or traumas always are often found in children with PSB. Finally, we will be outlining some key considerations when you find out a child might be having problematic sexual behaviors and identifying when to seek professional help. Understanding the considerations that need to be looked at and responding the most effectively to help the child as quickly as possible is important. There are so many people who might be involved in decision making about what happens with the child that is displaying problematic sexual behaviors. They may be involved in many types of systems. Just look at this list. The systems involved might be the caregivers, any county caregiving system, other family members, child protective services, law enforcement of various types, victim advocacy, behavioral and mental health providers, school professionals, medical providers, other professionals like speech therapists, occupational therapists, and the faith-based communities. Collaboration and coordination efforts are the most helpful to get the family the help they need as soon as possible and the child help that they need as soon as possible, and everybody working together towards the same goals and efforts. A consideration for safety must be looked at. Is the child still safe to be in the home, school, or community? residential, and inpatient treatment are highly expensive and may not be needed. However, children with severe psychiatric concerns or who are highly aggressive may need these higher levels of care for treatment. When determining if a child can remain at home, in the home during outpatient treatment, consider the parental capacity to provide the supervision and the safety plan that would be put into place during the initial stages of problematic sexual behavior cognitive behavioral treatment. With parental capacity not an issue, would the child also respond to this appropriate supervision and guidance? In addition, what does the other family members want? When they are calm, talk with them so that they can rationally think this through. Also, you need to look at what the other child's strengths are, what the other family member's strengths are, and are there any vulnerabilities of another child in that home that increases the risk of the child remaining in the family home? How about school? Can the child remain in the school? First, you need to take a look at how the child responds to adult guidance and supervision regarding other behaviors and tasks. How impulsive is the child? Can they learn to self regulate? Have they already learned to self regulate in other areas? What are the child's strengths? Finally, the school often does not need to know all the details, but there should be a consideration of what information is needed to keep other children in the school safe and the child with a problematic sexual behavior concern safe. Once again, collaboration within the different systems for safety planning is important. Were you the first to have to address a problematic sexual behavior in a child? It's very important, if you're this person, to give the child and family hope, but also to relay that the situation is serious. Make sure initial safety steps are outlined, additional supports that might be needed are put into place, and maintain communication and discuss the importance of continued communication during the process of dealing with this behavioral concern. The questions that need to be asked relate to how often the behavior is occurring, who it's with, and if it's not developmentally appropriate, any harm that can be described, and if the child is responding to the redirection or behavior, and if it's continuing even after this redirection, if there was any force, coercion, or aggression of any kind used, and if the behavior is identified as problematic sexual behavior, then remain calm but matter of fact when speaking to the child and caregiver. Focus on the facts and remain objective. Instill hope and link the family for support. We need to remember these are first and foremost children with behavioral issues. Think about how you would want to be treated. Acknowledge the seriousness of the situation, but give a sense of hope. Contact children and youth, do a child line if appropriate, and or call law enforcement when appropriate. The local child advocacy center can facilitate collaboration, coordination of services, and if appropriate, forensic interviews. They make referrals as appropriate, and if appropriate, the problematic sexual behavior, cognitive behavioral therapy, school age program can be contacted. These services will take referrals regardless of child protective services or law enforcement involvement. Although we cannot start PSB CBT until an investigation is over, we can start that initial stages of safety planning and establishing the therapeutic relationship, getting some more increased understanding of family dynamics and child concerns. Also, remember to designate someone to be in charge of safety planning if that's not your role. It needs to be done very quickly. If the other child or children who were involved are impacted or upset or harmed, please refer them for trauma screening or assessment. To finalize our presentation, we just have offered some resource information. The following slides are references for websites that provide additional information on trauma and problematic sexual behavior. They include the National Center on Sexual Behavior of Youth, the National Child Traumatic Stress Network, which is funded by SAMHSA, the Association for the Treatment of Sexual Abusers, Indian County Child Trauma Center, which mission is involved in the Native American community. And these two booklets, the Taking Action booklets and Stop It Now information, is really good information for helping with these kinds of concerns also. We want to thank you for taking the time to learn about problematic sexual behavior cognitive behavioral therapy. If you have any questions, please feel free to contact us. My email, Deborah Bell, is dbell, Deborah as in D, DBELL at CenClear.org. If you would like to reach the project director for our grant, which funds the Healing After Trauma program and provides the problematic sexual behavior treatment, this is Lori Yarger, Yarger, LYARGER, at CenClear.org. We would be willing to answer any of your questions and provide you even more information if you would like that. Please email us anytime that you would like. Thank you once again for taking the time to learn about problematic sexual behavior, cognitive behavioral therapy, and we hope you have a wonderful day.